So let us start by discussing the acute gingival lesions. So acute gingival lesions, they can arise due to the physical or chemical injury to the gingiva. The physical injuries such as accidents from a hard objects, aggressive toothbrushing, they can damage to the gums. Moving on to the viral infections. The viral infections, they include acute herpetic gingival stomatitis, herpangina, uh, hand, foot, and mouth disease, measles, herpes, varicella zoster virus infection, or the glandular fever. They are one of the viral infections that are known to cause the gingival lesions. So these infections, they can lead to painful sores and ulcers in the gums. The bacterial infections, they are anak, necrotizing ulcerative gingivitis, tuberculosis, syphilis. The fungal diseases can be candida, gingival abscess. So let us start with the necrotizing ulcerative gingivitis. So this condition, uh, the necrotizing ulcerative gingivitis, it is known for its sudden onset. So it is a painful, inflammatory, destructive disease that can affect the marginal and the papillary gingiva. So NUG, it is known for its sudden onset and it is associated with uh, episode of debilitating disease or acute respiratory tract infection. The debilitating disease refers to the medical condition that significantly weakens the body and uh, and limit the person's ability to carry out daily activities. Now, what are the factors that have an involvement in the history of anak? So, first of all, factors like prolonged working without adequate rest and psychological stress. Uh, they they often feature in the history of individuals that are affected by NUG. Now let us examine the clinical feature and sign that that characterize the NUG. So first of all, the intraoral signs and symptoms. Orally, you will see punched. So remember, punched out crater-like depressions. Very important for your exam. Punched out crater-like depressions. They are at the cleft of the interdental papilla. So these lesions would involve the marginal gingiva and rarely the attached gingiva. So remember, these craters, they are covered by pseudo membrane. Slow. So grayish pseudo membrane slow, uh, clearly demarcated from the remaining mucosa by pronounced linear erythema. Now there are two type of ulceration that can be seen in neck. The one is the lateral ulceration and necrosis affecting the buccal wall of papilla and margin, and other are the deep ulceration involving the necrosis of embrasure tissues. So this differentiation is due to the distinct blood supply sources for the gingival tissue. Additionally, apart from that, you can see is apart from that you can see is gingival hemorrhage, significant bleeding, etc. The lesions associated with NUG, they are highly sensitive to touch. The patient often complains of radiating gnawing pain. that is intensified by consuming spicy or hot food and during chewing. Apart from that, there is metallic taste. So there is a metallic foul taste in the mouth, and patient they complain of excess amount of pasty saliva. So these are the sign and symptoms of anak. You can see high fever. Anak in severe form can lead to increase in the body temperature, indicating the intense immune response to infection. The heart may be elevated due to the body's effort to combat the infection and the inflammation that is caused by the anak. So, what are the other name of NUC? It is also known as Vincent infection, trench mouth, or acute ulceromembranous gingivitis. That is important for your exam point of view. More recently, research, as highlighted by Loche, he have described two main flora that is associated with the NUC. One is the one is the constant flora. The constant flora it consists of organisms, fusospirochetal organisms along with the bacteroids. So these bacteria they are consistently present in the case of NUC, whereas other is the variable. So this category comprises of diverse range of bacterial types that can be present along along the side the constant flora. So the variable flora it can differ among individual and might include various bacterial species. Now immunological studies they have spotted that the bacteriological findings by demonstrating the increased level of IgG and IgM antibodies against spirochetes. So particularly the intermediate size spirochetes and Prevotella intermedia. So electron microscope studies they have revealed the presence of three types of spirochetes. They can be small, intermediate, and large spirochetes. The most prevalent being the intermediate, up to 90% of in number. Now let us discuss the local predisposing factors. So trauma to gums, whether from the mechanical injury or continuous irritation, can create site-specific susceptibility to the NUC. Smoking, it is strongly correlated with increase. Smoking, remember, it is related to increase risk of NUC. It is because of the toxic effect of tobacco on the gingiva, vascular changes that are induced by nicotine that may contribute to this association. Periodontal pockets, deep periodontal pockets and areas like paracoronal flap around the partially erupted teeth can serve as incubating zones, contributing to anak development. Coming to the systemic, what are the systemic predisposing factor? They can be nutritional deficiency, particularly vitamin B, C. They can attenuate the response of gingival tissue to increase pathogenic flora. Next is the debilitating disease. Debilitating disease conditions like heavy metal intoxication, severe GIT disorders, blood disorders like anemia, leukemia, they may increase the susceptibility to anak. So that can be considered in the systemic predisposing factors. Apart from that, uh, is the psychom, psychomotic psychosomatic factors. Uh, the alteration in digital and gingival capillary responses to increase autonomic nervous activity that can be linked. disturbance disturbances that could lead to change in hypothalamic pituitary adrenal axis. They may also contribute to predisposing factors that could lead to ONUC. Now let us discuss the classification. According to Horning and Cohen, the NUG can be classified into 7 different stages. Uh, Stage 1, when there is a necrosis of the tip of interdental papilla. When there is necrosis of entire papilla, it's stage 2. When it extends to gingival margin, it's stage 3. When the necrosis extends to attach gingiva, to the buccal and the labial mucosa, exposing the alveolar bone, perforating skin and chin, it's stage 7. According to Pindborg, the classification is according to stage 1, 2, 3, 4. Stage 1 is the erosion of the tip of papilla. Stage 2 is the lesion extending to the marginal gingiva and causing potentially a complete loss of papilla. Stage 3 involving the attached gingiva, and stage 4 is the involving the exposure of the bone. Now let us discuss the histopathological examination of lesions that are associated with NUC. First of all, the surface epithelium, it is destroyed in NUC lesions and it is replaced by pseudomembrane structure. So that consists of that is composed of fibrin, necrotic epithelial cells, PMN, and various other microorganisms. So that are the epithelial involvement. What are the underlying connective tissue changes? The underlying connective tissue, it will show there will be hyperemia. That means there will be increase in the blood flow, and there will be you will see numerous engorged capillaries that will show infiltrate of PMN, polymorphoneutrophils. So plasma cells that can be seen at the periphery. Now the Liftagan, he categorized the lesion into 4 zones based on the relation between the bacteria and the tissue zone. The first zone 1 is the bacterial zone. So that is the most superficial zone and it consists of various bacteria that may include spirochetes, small, medium and intermediate and large type. Zone 2 is the neutrophil rich zone. It consists of numerous leukocytes, predominantly the neutrophils, along with the bacteria including various types of spirochetes. Third is the necrotic zone that would consist of dead tissues, a remnant of connective tissue fragments and numerous spirochetes. The zone 4 is the zone of spirochete infiltration. So the tissue here is well preserved and it is infiltrated primarily by spirochetes of intermediate and large size without the presence of other organisms. Now the diagnosis. Diagnosis can be done on the basis of clinical findings, that is either gingival pain, ulceration or bleeding that could be seen, the bacterial smear or microscopic examination of the biopsy. So these are the differential diagnoses. The treatment on day 1 for the non-ambulatory patients, gently remove the necrotic pseudomembranous with the pellet of cotton saturated with hydrogen peroxide. The patient is advised bed rest and mouthwash rinse. It is done every 2 hours with the diluted 3% hydrogen peroxide. Apart from that, systemic antibiotics that could be given, like the penicillin or the metronidazole. After 24 hours, a bedside visit should be made. The treatment again include the gentle swab the area with hydrogen peroxide. In case 3, the condition would be improved. Start the treatment for the ambulatory patients. So for in the first visit for the ambulatory patients, you have to give topical anesthesia, remove the pseudomembrane and non-attached surface debris area. It is cleaned with warm water. Superficial calculus, it is removed with ultrasonic scalers. Apart from that, antibiotics can be prescribed and subgingival scaling and curettage are contraindicated. So these are the instructions that are given to patient. Avoid smoking alcohol. Rinse with 3% hydrogen peroxide and water for every 2 hours. So in second visit, curettage and scalers, they are added to the instrumentation. On third visit, scaling route planning, it is repeated plaque control instructions that could be given. Hydrogen peroxide rinses are discontinued. Apart from that, gingivoplasty, systemic antibiotics or sportive systemic treatment and nutrition supplement that could be given. So these are the differences between the NUC and the herpetic gingival stomatitis. The next is the acute herpetic gingival stomatitis. It is caused by the herpes simplex 1 and 2. So it is mainly caused by herpes simplex 1 virus. So it is most commonly seen in children under the age of 6 years. It can also be seen in adults. So primarily observed in children under the age of 6 years, but can also occur in older individual. It equally affects both the male and female. While many individuals may experience asymptomatic primary infections, symptoms can include sore or lesions in the oral cavity, fever, swollen lymph nodes, and general discomfort. The herpes simplex virus typically remain latent in the neuron ganglion after the primary infection. In about a third of world population, secondary infection may occur due to trigger like the sunlight, trauma, fever, or stress. So secondary manifestation that can include the herpes labialis, herpes stomatitis, genital herpes, ocular herpes, etc. So you can see the appearance of secondary herpes stomatitis that can present as vesicle on the palate, gingiva or mucosa that may stimulate the latent virus in the nerve ganglion. So clinical appearance, you will see a diffuse shiny erythematous involvement of the gingiva as seen here. The infection, it can manifest on the various oral surfaces including gingiva, labial and buccal mucosa, soft palate, pharynx, sublingual mucosa and the tongue. Vesicles form within around 24 hours of the infection. They later rupture, leading to formation of painful ulcers that are characterized by red elevated margins and contain yellow grayish white portions. Sometimes the primary herpetic gingivitis may occur without clear vesicle formation, so that is marked by diffuse red shiny discoloration and swollen gingiva. So the disease, it typically lasts for 7 to 10 days. After that, the ulcer heals. There is initial diffuse gingival redness and swelling that persists for several more days. So this condition would cause generalized soreness. So patient would feel difficulty in eating, drinking, and maintaining oral hygiene. The rupture vesicle, they are sensitive to touch. So the patient would feel temperature changes. Certain foods and coarse foods in the infants may result in irritability, and refusal to eat. Apart from that, you can see the extraoral symptoms, signs that could be fever and generalized. The patient may feel fever, and apart from that, there would be loss of appetite, lymphadenopathy. So these are the extraoral symptoms. After the primary infection remains latent in the nerves, if reactivation occurs, it causes herpes labialis. So this figure was asked in your one of your entrance exam in the and it identify it was herpes labialis. Now, what are the diagnosis can be made on the history and clinical findings apart from the biopsy. So these are the differential diagnoses. On histopathological, you will see the virus would affect the epithelial cells that would show ballooning degeneration. Apart from that, there will be a acantholysis, that is loss of intercellular connective tissue. Apart from that, you will see special cells that is known as Jank cells. So these infected cells, they can fuse to form a multinucleated cells. So timely diagnosis, it is important for the early treatment, as antiviral medication can affect the disease course and reducing the symptom and prevent the reoccurrence. So diagnostic approach would be based on clinical findings, patient history, confirmatory test like the virus culture, immunological test using monoclonal antibodies or DNA hybridization technique, they can be used. The next is the pericoronitis. Pericoronitis refer to inflammation of gingiva surrounding the crown of the partially erupted tooth. It is seen most commonly around the mandibular third molar. So primarily seen around the partially erupted or impacted third molar. So the space between the tooth crown and overlying gingival flap, that is known as operculum. So it creates an ideal environment for accumulation of food debris and bacterial growth. So without evident sign or symptom, the gingival flap, it is inflamed and infected. So acute pericoronitis, it can be triggered by factor like trauma, occlusion, or presence of foreign objects trapped under the gingival flap like the food particles. So they will exacerbate the inflammation. So patient would feel pain, discomfort, radiating pain to ear, throat and floor of mouth. Swelling, lymphadenitis could be seen, fever, leukocytosis, malaise. They are the few symptom. Systemic complication that could be seen. So treatment: warm water flush along with the topical anesthetic agent. The flap, it is reflected with scalar and underlying debris is also removed. Copious fluid intake. Systemic antibiotics can be given if the gingival flap, it is swollen, and fluctuant anterior posterior incision. To establish drainage, it is made with the PP blade. And in next visit determination, it is made whether the tooth have to be retained or not.